Hello, I'm Richard Hobbs. I'm head of primary care at the University of Oxford, and I'm delighted to have been asked to give this keynote at the 25th Immunisation Coalition Annual Scientific Meeting. I'm only sorry that I can't be joining you in person in Melbourne, so I hope the rest of the meeting goes well. Well, let's just pull up my slides that I'm going to present. Basically, it's going to be a rapid canter through the primary care response to COVID during the UK pandemic. And I'm going to make some observations about the contribution of primary care, both to the clinical services provided, but also in relation to supporting research that was conducted within primary care in the UK. And I've put my disclosures here on the bottom of the slide. Well, this is what I'm going to cover. I'm going to talk about the first clinical response that fell on primary care, some words about vaccination and surveillance, and a very important but rather unrewarded in terms of being cited for this contribution during the pandemic, but the contribution from primary care to public health, and then a few words at the end about clinical trials around COVID. So in terms of the first clinical response, obviously March 2020, well, actually not obviously, but when the pandemic first took hold in the United Kingdom in March 2020, it's fair to say the country was pretty unprepared, despite the fact that in the University of Oxford, we had been aware that there was going to be a global pandemic in early January and had started taking measures to respond to that. It took until March before the UK government really took the threat seriously and started initiating public health measures. But it meant that the country was unprepared for the pandemic, and that was particularly true in primary care, who bore the brunt of the early waves. There was no PPE supplied to primary care. There was no advice about how practices might triage into acute respiratory centres. Suffice to say, it was a very difficult time for British GPs. They also, though, did start advising the high-risk patients about the importance of actually shielding themselves from possible infection. There were then a whole raft of public health interventions around hand washing and surface cleaning. There was this initial wrong focus on fomite transmission. And it took a while really before the recognition that this was a principally aerosol-driven infection. And then as hospitals filled and ICUs became close to capacity, then we had the national lockdowns, and that resulted in these massive social restrictions taking place. And we had some 3 national lockdowns at different periods during 2020. It was really quite a confusing time, though. There were a lot of rules that kept changing, which meant that the public actually did become confused. Ministers themselves became confused about what guidance was operating at any particular time. But in the background, GPs obviously carried on where possible, seeing patients, although there was big pressure on patients to not contact health services unless they were becoming quite poorly. So I think it's true to say that we were pretty disorganized in the United Kingdom. I think there was shifting leadership. At times, the government actually did appear to be in control and were giving consistent and important advice, but that varied at different points during the pandemic. And scientists didn't always agree as well, which also created confusion. And I think it's true to say we could have done very much better in terms of protecting healthcare staff. It was only really in ICUs and in emergency rooms that PPE and support was provided to clinicians and nurses. it was pretty Wild West in primary care indeed. PPE wasn't actually sent to practices until July 2020, some 4 months into the pandemic. The other big mistake was a hospital discharge policy into nursing homes, and that resulted in very high numbers of very elderly becoming infected. And indeed, about 40% of the deaths in wave one of the pandemic actually were in nursing homes. And that, alongside the fact that nursing homes were shielding and families weren't able to visit their loved ones in nursing homes, yet many of them were contracting COVID and succumbing, I think is a public tragedy. We also had very limited testing early on, although that changed during the pandemic, but is now completely dismantled again. But clearly, the ability to test is actually quite an important thing to have in the system. And I think hopefully we will have learned some lessons about how to better triage patients in future. So if we look at the what happened in general practice, then there was this very dramatic drop off in consultations during 2020 in green there, with almost a halving of consultation demand pretty immediately the pandemic struck. And then that was associated with also a shift in consultation type. So there were fewer consultations, and about half of them were non-face-to-face consultations, mainly telephone, although some practices did embrace a more digital approach to consultations. And one of the unfortunate aspects of the pandemic is that perhaps that digital consultation option has not persisted as one might have imagined it could have done. There was also a big change in referral patterns, again, almost immediate, and that was inevitably associated with trying to protect hospital beds. There was a fairly rapid recovery, so that by late summer, by September or so, hospitalization referrals had sort of plateaued again. But you'll note that there was actually a difference. They still didn't return to pre-COVID levels, and this was at least partly driven by persisting patient-changing behavior. Patients were more reluctant to visit healthcare facilities, particularly hospitals, and that has been a big legacy issue for us post-pandemic, because clearly there was a lot of early disease that was not detected because patients were presenting later than they otherwise would have done, and therefore this impacting on referral rates. Now, the second big initiative from primary care related to COVID vaccination. Indeed, the UK was a particular hot site for actually delivering a lot of the manufacturers' COVID trials. So GPs actually were doing a lot of the research around the vaccinations and helping them get registered with licenses. But they also effectively delivered the national rollout of the vaccination program when it occurred. So this slide basically shows the numbers of COVID infections which were occurring in the UK by the various waves. So this is 2020 here, waves 1 to 3, and then the massive numbers of patients becoming infected in the first half of and second half of 2021. That's when really very large numbers in the population were infected. So although the pandemic was at its most impactful in terms of serious COVID in 2020, the actual numbers of people becoming infected and repeat infections was much bigger in 2021, with some five-fold increased rates of COVID compared to those in 2020. Now, obviously, one of the big success stories was this rapid rollout of effective vaccines, effective against serious COVID, even if they became quite rapidly less effective at actually stopping patients being infected with COVID. They retained this protection against serious COVID. And once they became available in December, this incredibly rapid immunization of the entire at-risk population, such that within 3 months, virtually the entire adult population had been offered at least an initial COVID vaccination, and then very high offering for the second doses. And that had quite a dramatic impact in terms of serious COVID, because here is the same chart that I showed you earlier in relation to the numbers of infections with COVID. And here are the same rates, but looking at hospital admissions, with this very, very high hospital admission rate in wave 1, even more dramatically impactful on people's health, wave 1, then high rates in waves 2 and 3. But the subsequent waves, where actually numbers of COVID infections were at the greatest, dramatic reduction. And therefore, during the pandemic, vaccines reduced the hospital admission rate from about 7% of those infected to under 1% of those infected post-vaccination. And in terms of deaths, even more dramatic effects, with these very high death rates in waves 1 to 3, and then hugely diminished death rates post-vaccination, with a 2% mortality seen early on in the pandemic, dropping to a 0.1% mortality rate post-vaccination. And it was really a dramatic success in terms of the proportions of the population over 12 who were vaccinated, although you can see even early on a decline in people accepting the vaccination offer. And that's going to be a persisting theme for us in general practice, is vaccine hesitancy, which became a problem early on in the vaccination program and has only become worse and has actually extended to other vaccinations as well. And I'm sure that's something you'll have talked about at the meeting, which is this how we respond to vaccine hesitancy, particularly evident in younger people. Therefore, we need to get public health and personal messaging in that population, and in patients from ethnic minorities, particularly Black patients in the UK, where vaccine hesitancy affecting about 50% of this community. So, important lessons for us. Primary care is also very involved in infection surveillance. Now, this wasn't across all general practices, but we run sentinel surveillance practices in the UK, about 300 practices set up to do more intensive phenotyping with virology and serology. And basically, this sentinel general practice service been providing flu surveillance rates for many years, and indeed detecting the usual seasonal nature for influenza, although the 2009 influenza epidemic was actually late September. That network was rapidly tasked towards COVID early on in the pandemic. And basically what this shows is a comparison between the GP Sentinel COVID surveillance network and the public health laboratory surveillance system that is set up specifically for epidemic surveillance. And you can see that the GP system, which is a low-cost system because it's only a bolt-on to existing clinical service rather than a specially developed service for public health laboratories, is actually detecting the same volume of infections, but earlier, about a week earlier. So low-cost primary care surveillance is both reliable in terms of the extent of infection in the population, but also more rapid in terms of detecting cases. And indeed, the very first case of swine flu in the UK and the first case of COVID that wasn't travel-related in the UK, both of these first case patients were detected by the GP surveillance network. Well, I said that perhaps a hidden success from general practice during the pandemic was the public health messages. And I think there are two things I'm going to talk about that illustrate that. And the first of those are the fantastic work that was done about more personalised recognition of those at greatest risk of serious COVID. And actually, these sort of scoring systems were developed quite early on in the pandemic from GP data. And this is Open Safely, which looked at about half the UK population to start with, but is now actually operating on the majority of the population in the UK, and showed that basically patients who were more likely to suffer severe COVID were patients who had degrees of immunocompromise or immunosuppression, perhaps associated with cancers, particularly hematological cancers, but also immunosenescence, i.e. reduced immunity with age, or with established chronic disease states such as diabetes and vascular disease. And indeed, we operationalized these data into what became the Q-COVID score, which basically provided a numeric indication of the individual's risk of severe COVID. And this general practice derived risk score was used in the UK to both determine those patients who had the most to gain from shielding, so giving them more information about their personal risk, but it was also used to determine the order in which we rolled out the vaccination program, when obviously you wanted to vaccinate those at greatest risk first. And indeed, the same databases were also used quite early on to look at the safety associated with the vaccination program. And although inevitably huge numbers of vaccinations given are going to develop some risks of adverse events, the ChAdOx developing central venous thrombosis being an incredibly rare but serious adverse risk associated with vaccination, detected in other viral vector vaccines as well, but normally not noticed because it's such a rare phenomena, affecting perhaps 4 to 6 in a million patients vaccinated against the background rate, which is 1 or 2 in a million, or the cardiovascular risks associated with the mRNAs. But what this slide also illustrates is that for every adverse outcome associated with the vaccines, for patients who did not get vaccinated but then got COVID, those same adverse events were occurring in much higher rates. So you're 5 times more likely to get a cerebral venous sinus thrombosis from being non-vaccinated and catching COVID than by being vaccinated. And again, important messages for the population. Now, here's a particularly unsung success of general practice, which is the recovery of disease prevention rapidly during the pandemic. Now, what this slide shows is the numbers of patients having serum cholesterol testing, which plummeted almost immediately the pandemic occurred. But look, by September, so less than 6 months into the pandemic, practices returning to doing their prevention testing again effectively. And for tests that you couldn't stop, this is INR testing for patients on warfarin. Even during the pandemic, no drop-off in test rates. So something like INR you have to carry on doing, and indeed British general practice continued to deliver it, although they also rapidly converted patients from warfarin onto DOACs. And that, again, was a big success story during the pandemic, which was not COVID-related, but was a big public health response to keeping patients safe. And that was also true of other preventive measures, such as blood pressure measuring. Took a bit longer to return to pre-COVID levels, but a rapid recovery from the almost instant stopping of doing regular blood pressures during the pandemic. And here's liver function tests showing the same pattern. So the final comments I've got to make about the British GP response to the pandemic relates to their contribution to some of the out-of-hospital COVID treatment trials programs. And there were 2 very large national platform trials that looked initially at repurposed drugs. That was the principal trial, and then looked at the novel COVID antivirals. That's the panoramic trial. And both of these trials were designed and organized by academic GPs in the UK, actually based out of Oxford, but were delivered within British general practice. And they both had high degrees of digitization associated with them, so that patients were able to recruit directly into them. We did online consent digitally, and also for a proportion of the population were able to access the summary care record and were able to do eligibility checks centrally, reducing some of the burden on practices, and indeed ran a research central research pharmacy to be able to courier medicines and COVID tests to patients in their home. So during the pandemic, we did these several arms that were looking at repurposed drugs, all of which had impactful publications, including showing that the drug actually had no benefit at all, whether it be antibiotics or colchicine, and indeed resulted in alerts to say, don't use doxycycline or azithromycin in patients with COVID. It derived no benefit, and you wanted to reserve the antibiotics for those bacterial infections. But we did have one arm, this is pre-vaccination era, that showed benefit, and that was the inhaled budesonide, which showed a significant 4-day reduction in rates in recovery from COVID. So that was a highly significant benefit that was maintained, full recovery, and all the parameters looking at recovery better with the inhaled budesonide versus routine care. And also it showed a trend for benefit in terms of hospital admissions. It just missed the significance in terms of probability in the primary, where we had looked at all controls, not just the controls that were being randomized at the same time of the budesonide. This was in the end, I think, a mistake. We did it to increase the power of the study, but I think the shifting variants and therefore the different likelihood of serious event rapidly during the trial made that, in retrospect, a poor decision. But if we looked at the secondary outcome, where we compare patient controls that were recruited at the same time as the budesonide arm, which is basically the concurrent population, which is the more conventional way you design a clinical trial, in fact, it did show significance for hospitalization, so significant reduction in hospitalizations from twice daily budesonide. We then shifted the effort onto the antivirals and have looked at 2 so far, molnupiravir and Paxlovid, which continues. And we're looking basically at the elderly or patients who had additional risk factors for severe COVID. Remarkable trial in terms of the rapidity of recruitment. So this was a monumental effort by British GPs. We recruited nearly 25,000 acutely ill patients in 4 months in the molnupiravir arm, and basically showed that for the primary, which was severe COVID associated with hospitalizations or death, there was no benefit associated with the molnupiravir. And this was despite the fact that the trials that had occurred that got the registration for molnupiravir had shown a significant benefit in terms of reduced hospitalizations, but these were in patients who had not been vaccinated, whereas panoramic is in a largely vaccinated population. There was no additional benefit associated with molnupiravir, although similar to the budesonide, there was a 4-day benefit in time to recovery. So no benefit in terms of serious COVID, but a benefit in terms of time to recovery. And we concluded from these data that perhaps molnupiravir might be beneficial in certain patient groups where recovery, such as key workers, where recovery is clearly important. Just a word of historical interest here, because these major COVID trials were organised by my department here, the Department of Primary Care in University of Oxford, which we renovated. This was the outpatient building of the original Radcliffe Infirmary Hospital from the 18th century. We renovated it to occupy as the primary care department. And there's a blue plaque on the wall of this building, which celebrates the fact that the very first patient in the world was administered penicillin in this building in the 1940s. And so track forward 80 years, and this was the centre of the UK's response to clinical trials in relation to COVID. So I hope that's been an interesting canter for you. I've talked about how we were really pretty unprepared for COVID in early 2020, but general practice went on to play a pivotal role in preventive activity, in delivering the vaccine programme, in providing the data that generated COVID risk estimations, and supporting the research that explored new treatments, including vaccinations and drugs. I think it's early days, but clearly the impact of long COVID is going to particularly fall on general practice. And I think I would just close by reminding ourselves that the one thing COVID was an unexpected stress test for health systems. And what it showed in the UK is that we have many patients with established risk factors that are either not being treated or are being inadequately treated. And it's this population that formed the bulk of those that ultimately died during the pandemic. So the big lesson for us is that we should be more effectively implementing evidence-based medicine amongst those that we know are at risk for established risk factors. Thank you very much.